So hepatic tumors, there's 6 different tumors I want you to know. 3 of them are malignant, so we'll talk about those 3 at first. And there's also 3 benign tumors listed below. So let's start from the top and go down. Hepatocellular carcinoma is something we've talked about quite a bit now, but we haven't addressed directly. This is our most common primary liver cancer, and it's usually in the setting of chronic liver disease and cirrhosis. And for this reason, anybody who has cirrhosis is supposed to be scheduled to receive routine screening abdominal ultrasounds to evaluate for HCC. And some of the risk factors, it's pretty much anything that can cause cirrhosis. So we've already talked about some of these. We've talked about chronic viral hepatitis. We've talked about alcoholic and non-alcoholic liver cirrhosis, autoimmune hepatitis. And later on, we'll talk about these other 3, hemochromatosis, Wilson's, and alpha-1 antitrypsin. So anything that can cause cirrhosis, which is consistent with what I've tried to teach you throughout the GI unit, is anything that can cause chronic inflammation increases your risk for cancer. So this is no exception. One thing I haven't mentioned, and I just want you to realize it is a risk factor, is that there's a type of species called Aspergillus, which can produce an aflatoxin, and that can actually increase your risk of hepatocellular carcinoma as well. So how does HCC present? You could have some symptoms like right upper quadrant pain, weight loss, and a palpable mass. You could have, and generally speaking, this would be in somebody who already has cirrhosis and may have some sequela of that cirrhosis, like jaundice, ascites, splenomegaly. What I want to reiterate, though, is that this can still be asymptomatic, and that's why we do our screens. That's why we do our right upper quadrant ultrasounds to evaluate for any liver, for any HCC or suspicious masses in people with liver cirrhosis, because it doesn't always present symptomatically. And a good biomarker that you can use to assess for hepatocellular carcinoma is this elevated alpha fetoprotein level, or AFP. You can also attempt to diagnose it, maybe not diagnose it, but you can, if you do imaging studies like the ultrasound we talked about, or sometimes you can do a CT or an MRI and find a concerning mass. And once you've done that, what you should do, you should never say, oh, this person has an elevated AFP, oh, or this person has a somewhat suspicious mass on ultrasound. That's not going to give you the diagnosis directly. That'll just give you a suspicion for it. The gold standard is still to biopsy that mass to confirm HCC. And so HCC has a few different treatment options. You can surgically resect the mass if it's small enough. A lot of times they're going to have repeated doses of radiofrequency ablation or chemoembolization, which just means that they can either target that specific, either the blood vessel that it's attached to, or they can give targeted chemotherapy to that region specifically to help treat that. You can also treat it with something called VEGF inhibitors. These usually just stop your blood vessels from proliferating. And so again, because the liver is such a highly vascularized region, as you've probably already seen, you can see how embolization would kind of cauterize some concerning blood vessels. You can see that this VEGF inhibitors would try to turn off the liver's ability to create more blood vessels in that region. And if possible, if they are a candidate, you should consider liver transplantation in anybody who's a candidate. This has a very poor prognosis. Their 2-year survival is less than 50%. And some complications, you could get Budd-Chiari syndrome because of invasion into the hepatic vein, causing a blood clot. And you could also get metastases spread to other sites like the lungs, bones, and adrenal glands. Now let's move on to another type of liver cancer, liver metastases. And I mentioned to you that HCC was the most common primary liver cancer. Well, liver metastases are the most common liver cancer at all. And so where do these liver metastases start? Well, generally speaking, they usually start in either the GI tract lung, or breast tissue uh, throughout the unit, whether it was gastric adenocarcinoma, colorectal carcinoma, pancreatic carcinoma, didn't really matter. Anywhere in the GI tract, I told you that the most common site of liver metastases was the GI tract. So keep that in mind. This will present, the presentation will be dependent actually on what the primary tumor is. You'll usually see weight loss. You could get liver disease potentially if the liver metastases are very, very widespread. And you're going to get whatever symptoms are associated with your primary cancer. And on imaging, you're going to find multiple liver nodules, and that's important. So here's a couple examples of liver metastases and how they like to test this. They like to give you this picture, and then they'll ask you where the primary cancer is, and they'll have liver as an option. But just keep in mind, if you ever have multiple liver nodules like this or multiple liver nodules like this, that should tell you that it's actually not originating within the liver. It's probably originating somewhere else, like the GI tract is very common. And what's happening is that GI tract cancer is throwing all of its cancer seeds through the portal system, and they're just getting embedded here and starting to form little cancers all throughout your liver. So the last malignant tumor that I want you to know about is something called Hepatic Angiosarcoma. This is a rare vascular tumor with a very, very, very poor prognosis. It's got a 100% mortality rate at 2 years. And so this tumor forms if you inhale certain carcinogens. And the one they really, really emphasize on tests is vinyl chloride. So they'll give you a patient, they pretty much have to give you a patient who's working in a factory creating PVC pipes or something of that nature in order to lead you to this hepatic angiosarcoma. The other way they sometimes test it is in arsenic, which can be found in your environment in general. Again, I haven't seen that tested because they'd have to be pretty explicit to tell you that there's high arsenic levels nearby. So in order to get this, just keep in mind this PVC pipe factory. If you ever see that, I want the light bulb in your head to kind of at least consider this hepatic angiosarcoma when you see PVC pipes, but also don't forget about this arsenic exposure. And so this will present with the same way that we've seen a lot of other cancers. You can get weight loss, abdominal pain, jaundice. You can get, the sequelae of liver cirrhosis. And so just as long as you know these risk factors, you can get this question right. Okay, so now that we've talked about the 3 malignant tumors, let's switch it up and talk about the benign liver tumors. And something I've intentionally done is I've put hepatic adenoma at the bottom of this list. I feel like whenever I talk to my classmates back in the day studying for step 1, hepatic adenoma was whenever you saw a benign tumor, you always wanted to pick hepatic adenoma. It's like I don't know, it's just the benign tumor that we learn most. And it's actually the 3rd most common. So I'll go in this order, and I want you to differentiate these because this is something that's tested. They want you to know what a biopsy would show for each of these 3 different benign tumors. So let's start with a cavernous hemangioma. This is the most common benign liver tumor, and it's caused by vascular malformations. And you'll see this more often in females between ages 30 and 50. And on histology, you're going to get these vascular regions and thrombus formation. So on a picture to the right, you can see a lot of vascular regions here, and you can see regions, the circle right here, you can see the thrombus that's starting to form. And you don't want to biopsy these if you can avoid it because there's a strong risk of hemorrhage. And now with FNH, or focal nodular hyperplasia, this is the 2nd most common benign liver tumor. It's associated with congenital AV malformations, and it can still be related to oral contraceptive use. And on histology, you're going to see this central stellate scar, which I've kind of highlighted one part of this scar. You can see it all the way through here. And finally, we'll talk about your favorite benign liver tumor, the hepatic adenoma. This is the 3rd most common, It's associated with oral contraceptive or anabolic steroid use. Again, it's common in adult women, and it's fueled by estrogen use, which means that during pregnancy, when your estrogen levels are really high, it has a risk of rupture. On histology, you're going to find a well-circumscribed nodule with a regular reticulin scaffold. So what does that mean? Well-circumscribed just means that you can tell the difference between, if I take this away, you can tell the difference between the nodule and associated tissues. And then the reticulin, you can actually stain this with reticulin to see if it has a nice normal reticulin scaffold. There's nothing concerning going on. And so right here, if you look at all these different cells, you can see each cell has a nice membrane. Everything's good. And you can treat this by, usually you want to just discontinue the estrogen fuel, so you discontinue the oral contraceptives or steroids. If the tumor gets very large, though, you might have to resect it. And here's a slide that shows you the differences between these three, and they usually don't give you a picture. They usually just give you the verbiage. So they'll say that they did a biopsy and it showed a central stellate scar, or they'll say they have vascular spaces and thrombi, or they'll say a well-circumscribed nodule with a reticulin scaffold. So you really do have to know each of these things, because all of these can happen in young women. Some of them are associated with OCP use. So that really doesn't help you to determine, oh yeah, this is definitely hepatic adenoma. It's really good to know each of these three conditions, as well as how they would describe it on a test. There's a few other hepatic tumors that I haven't mentioned yet. I just want to bring it up here. Cholangiocarcinoma, I'm going to talk about, as well as liver abscesses. Cholangiocarcinoma, we actually did discuss in the hepatobiliary lecture. It's just a cancer that originates within your bile duct cells, and it's usually resulting from chronic bile duct inflammation. And the risk factors that I want you to be aware of, you can get this from primary sclerosing cholangitis, as well as the Chinese liver fluke, Clonorchis sinensis. And so both of these are causing chronic inflammation, and that could lead to cholangiocarcinoma. What I wanted to spend a little bit more time on are liver abscesses. So liver abscesses are walled-off infections of your liver, and they can be caused by several different pathogens. So sometimes what will happen is that the bacteria that lives in your GI tract, like E. coli, Enterococcus, Klebsiella, sometimes those can sneak into your liver and they can actually form an abscess in that area. You can also get it to where the bacteria that might have infected your entire bloodstream, like let's say you have Staphylococcus bacteremia or Streptococcus infection, sometimes that can actually go through your bloodstream, deposit in your liver, and form an abscess as well. What I'll spend more of my time on, though, are these atypical presentations, because they are tested. So you can get a protozoa called Entamoeba histolytica that'll form liver abscesses. You can also get a helminth called Echinococcus granulosus that will form an abscess in your liver, or it'll form cysts in your liver more than anything. So let's first start by talking about Entamoeba histolytica. So this is a protozoa that affects 30 to 50 million people worldwide, so very common. It gets transmitted through cysts, ingestion of cysts in contaminated water sources. And you can see a cyst right here. And later on, we'll talk about the trophozoite here, and it's classically, it can consume these red blood cells, and that's what you're seeing here. So how does this pathogenesis work? So what'll happen is that somebody will ingest a cyst from a contaminated water source. That cyst will ultimately transform into a trophozoite, so it'll kind of mature into a trophozoite in our small intestine. And most of the time, you're actually going to get non-invasive disease. And what that means is that your trophozoite will attach to your intestine, and it'll start forming a ton of cysts that can be excreted in the stool, but it doesn't actually invade the intestine. It's very happy where it is. However, 10% of the time, you can get invasive disease. And this is where the trophozoite actually invades your intestine, which will form these flask-shaped ulcers. That'll enter your bloodstream and consume some red blood cells in the process. And then to top it all off, it will go to different organs in your body, like your liver, your lungs, and your brain, and it can form abscesses in those regions. So let's show that pathogenesis. So this is the GI lumen. You can have a cyst that matures into a trophozoite, and most of the time, it'll attach to your small intestine and just create a bunch of cysts. And so this is more common, non-invasive disease. They're not going to test you on the non-invasive type because it's not too dissimilar to other stuff. What they will emphasize, though, is this invasive disease because it has a few different unique characteristics that you're not going to see anywhere else. So again, it'll form these, the cyst will mature into a trophozoite that will not only attach to the wall, but it'll start burrowing through that intestinal wall and forming these classic flask-shaped ulcers, which they do mention on question stems. It'll enter the bloodstream, and there it can consume some red blood cells if it wants. And finally, it'll deposit in the liver, lungs, or brain and form abscesses. So this, how does this present? Well, because the trophozoites are physically burrowing through the intestinal wall and forming those ulcers, you could end up seeing bloody diarrhea as a consequence. You could also get abdominal pain for these same reasons, and fever because you have an infection. You can diagnose this either through the stool microscopy or antigen testing. And on colonoscopy, you'll see these flask-shaped ulcers. Like I said, they do like to mention that on tests. And you'll also see those trophozoites with engulfed RBCs. So normally on a test, they're not gonna say, hey, you have this person with these symptoms and their antigen tested positive for Entamoeba. That would defeat the whole purpose of asking the question, right? What they'll probably do is they'll give you these symptoms, and then they'll either say they had a colonoscopy which revealed flask-shaped ulcers, or they had a trophozoite with engulfed RBCs, or they might say, you know, the right lobe of the liver have some mass on it. So you'll have to kind of deduce that, okay, maybe this is not a cancer, maybe this is something else, maybe this is Entamoeba because of these, you know, classic presentation. And again, here's a picture of, they might show this picture or talk about it. They'll show you a trophozoite with a ton of red blood cells inside of it. So how do you treat this? So sometimes they like to emphasize they call them intraluminal agents versus systemic agents. So I'll kind of go over the treatment algorithm based on whether it's just an asymptomatic infection or an invasive systemic infection. So if it's an asymptomatic infection and you just discover this incidentally, usually, or on stool microscopy, for example, you can use intraluminal agents, and that'll kill all the cysts that are inside your lumen. So inside your intestinal lumen, you can use paromomycin or idonoquinol. If you have an invasive infection, you should consider giving metronidazole or metronidazole and another gram-negative. And I would say, as far as what's important for testing, is they do like you to know these intraluminal agents. They want you to know that paromomycin and idonoquinol can be used as an intraluminal agent to kill the cysts that are still in the intestine. Now we're going to switch gears and talk about Echinococcus granulosus. And Echinococcus granulosus is a protozoa, and it's classically associated with hydatid cyst formation in the liver. And on the left here, you can see some cysts, several hydatid cysts in the liver. And on the right, you can see one of those cysts just blown up for you. And what I want to do with Echinococcus, I want to talk about the life cycle, because they do like to test what animal is the intermediate host versus the definitive host versus the aberrant intermediate host. So I want to go over all that just so you're not confused on the test. So how this life cycle works normally is that what'll happen is that cysts will mature inside of intermediate hosts. And intermediate hosts are things like livestock, like sheep, cattle, and pigs. And once these cysts mature, they are excreted in the stool. From there, we have cysts that are now in the stool. They are ingested by dogs. And because dogs are definitive hosts, they can mature, these cysts can actually mature into their adult forms, so larvae and adult tapeworms. And I probably should have specified the difference between intermediate and definitive host. If you haven't figured it out yet, intermediate hosts are basically hosts that can help the pathogen, in this case, Echinococcus, it can help it mature to some extent, but that pathogen can never mature into its adult form in an intermediate host. And that's why we see that in sheep, cattle, and pigs, we see that it can mature into a cyst, but it cannot mature into the final adult form. And we're going to see the same thing later when we talk about humans, because humans are also intermediate hosts. On the other hand, dogs, as you can see, once the cysts were injected by dogs, they were able to mature into larvae and adult tapeworms because they are the definitive hosts in this case. And so once they've matured into these adult tapeworms, the dog feces will contain thousands and thousands of eggs that are being released by the tapeworms. And those eggs will be, again, ingested by those same intermediate hosts like sheep, cattle, and pigs. And you're going to have this cyclical pattern where those eggs can then mature into cysts, and then they'll be excreted and ingested by dogs, and you can see the cyclical pattern. And I'll just show this in the pictorial form just to make it even easier to understand. We have our cysts that are excreted from livestock. They're ingested by dogs, and they mature into adult tapeworms. Those tapeworms will release eggs, and those eggs will be ingested by the livestock, which will again mature into the cysts, and you have this nice cycle going on. So how do humans fit into all this? So what happens to humans is that instead of these eggs being ingested by their normal intermediate hosts, they'll instead be ingested by humans, which are considered aberrant intermediate hosts. So again, if we look at this picture, instead of the intermediate host, the normal intermediate host, livestock like sheep, cattle, and swine, ingesting the eggs, these eggs from dog feces will be ingested by humans. And so let's talk about what happens there. So these eggs ingested, they will mature into something called an oncosphere, and that will be able to secrete cysts. And all of these cysts can invade the intestinal wall, enter our bloodstream, and ultimately deposit in tissues. And on tests, they really love the hydatid cysts that form in the liver specifically. So keep that in mind. But it can also form in the lungs and brain, although I haven't really seen that on a test question. And so how do we treat this? You can give albendazole if the disease is limited, or sometimes you'll give this antiparasitic albendazole after they've had surgery, just to make sure that you've pretty much wiped out all of the pathogens. But especially in the case of significant cyst formation, you're often going to require surgical resection. And something they don't really test too often, but I just wanted to mention that this surgery, there's a few different ways to go about it, and you don't need to know how they aspirate it and inject alcohol and all that stuff. But just know that during the surgery, if a cyst does leak, it can form an anaphylactic reaction, or it can actually start seeding other areas of the body too. So it can be one of the complications that you have to worry about in these surgeries. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.